pancreatic neuroendocrine tumors. So for this we have used this table from your Bailey and Love. Now this table has your key features which is going to help you to solve almost all the major questions coming from your pancreatic neuroendocrine tumors. So first let's take a look at the characteristics of this pancreatic neuroendocrine tumors as a whole, following by which we shall discuss your WHO classification and then some important points with respect to your gastrinoma and your insulinoma. So over here if we look at insulinoma, the incidence being your 70 to 80%. Now this has a presentation of your weakness, sweating, tremor, tachycardia, anxiety, fatigue, dizziness, disorientation, seizures, right, and the malignancy chances are less than 10%. Then we have your gastrinoma, which has an incidence of 20 to 25%. Now the classical features or the presentations are your intractable or recurrent peptic ulcer disease, complications of peptic ulcer disease and your diarrhea, right, and it has a malignancy percentage chances of 60 to 90%. Then we have your non-functional tumors, incidence being your 30 to 50%. Now this present with your obstructive jaundice, pancreatitis, epigastric pain, duodenal obstruction, weight loss and fatigue, and the chances of malignancy include your 60 to 90%. Then we have your vipoma, which has an incidence of 4%, presenting to you with profuse watery diarrhea, hypotension and abdominal pain. Now this question has been asked multiple times previously in your exam, which is about your glucanoma. So they present to you with classically with your migratory necrolytic skin rash, glossitis, stomatitis, angular cheilitis, diabetes, severe weight loss and diarrhea, right. So this migratory necrolytic skin rash, which is suggestive of your glucanoma, it has a malignancy rate of 50 to 80%. So please remember this classical feature of glucanoma. Then we have your somatostatinoma, which has your incidence of less than 5%, presenting to you with cholelithiasis. So this is another important presentation which is exclusive to your somatostatinoma, right. Diarrhea and neurofibromatosis, malignancy chances are more than 70%. Then you have your carcinoid, which is less than 1, presenting with your flushing, sweating, diarrhea and edema. Malignancy percentage chances are your 60 to 90%. Then you have your ACTH-UMA, which is presenting with your Cushing syndrome. Malignancy chances is more than 95, right. And you have your JRF-UMA, which is less than 1, presenting with your acromegaly, and the malignancy percentage is unknown. So this particular table of your pancreatic neuroendocrine tumors is going to help you solve majority of the questions coming from the pancreatic neuroendocrine tumors. Now let's study a few additional points. Now regarding the World Health Organization net classification of tumor grade, so we have your grade 1, which is less than 2 mitosis and less than 3 Ki67 index. Grade 2, which is 2 to 20 mitosis per 10 high power field and a Ki67 index of 3 to 20. Then we have your grade 3 NET, which is more than 20 mitosis per 10 high power field and a Ki67 index of more than 20, and a poorly differentiated neuroendocrine tumor or a carcinoma would be having more than 20 mitosis per high power field and more than 20 Ki67 index, right. Now a few important points with respect to your gastrinoma. This is your Zollinger-Ellison syndrome. So it includes your fulminating ulcer diathesis in stomach and duodenum, recurrent ulceration despite adequate therapy and gastrinoma, right. So these are your classical features of your Zollinger-Ellison syndrome. So these features would be given as the clinical scenarios in your questions, which would help you to solve them. Then this is associated with MEN1, and we have studied in MEN1 that gastrinoma is much more common than your insulinoma. The most common location is your duodenum, and then the gastrinoma triangle is known as your Passaro's triangle, which has been shown in this image given below. So you have the boundaries, which is medially by the junction of the neck and body of the pancreas. Superiorly, it is by the junction of cystic duct and the CBD, and inferiorly it is by the second and the third part of your duodenum. Then your diagnostic laboratory features include your gastric pH less than 2.5 and your serum gastrin concentration is more than 1000 picogram per ml. If it is between 100 to 500 picogram per ml, then what we need to do is a secretin test. A pre-op localization can be done with the help of your endoscopic USG. And the pancreatic gastrinoma treatment would include a enucleation and a duodenotomy in case of Menvan syndrome. Then you have your duodenal gastrinoma, which would include, if it is less than 5, enucleation with overlying mucosa, and if it is more than 5 mm, then it would be excised with your full thickness excision of your duodenal wall, right. So these are few important features with respect to your gastrinoma. And then another important pancreatic neuroendocrine tumor which we need to know a little bit more in detail is your insulinoma. So this is your most common endocrine tumor of the pancreas. Highest incidence is seen in your 4th to 6th decade, right. Then 90% are your benign and solitary. Now they have your symptoms of neuroglycopenia, which is during fasting and your exercise. Now over here we need to differentiate it from a very important condition, which is your late dumping syndrome. So what would be your classical differentiating feature, right? Both have hypoglycemia. So in late dumping syndrome, if you recall, this hypoglycemia occurs after meal, whereas over here in your insulinoma it occurs during your fasting. So this is a very important differentiation that you guys need to remember. Now there is a classical triad seen in your insulinoma, which is your Whipple's triad, right. So what are your components of your Whipple's triad? So you have your symptoms induced by fasting, then you have hypoglycemia at the time of symptoms, and your symptoms are relieved by the IV administration of glucose. Then for imaging we have your endoscopic ultrasound, which has a positive detection rate of around 90%, and your visceral angiography with arterial stimulation when a sampling is needed when you have more than one lesion, and in cases of your negative endoscopic ultrasound. Now the surgical management would include your enucleation, which can be done with your laparoscopic techniques as well, and your medical treatment includes your diazoxide, which should be given in all the patients undergoing surgery, as it suppresses your insulin by your direct action. And in case of unresectable or metastatic disease, what we need to do is we use somatostatin analogs, everolimus, chemotherapy or chemoembolization is your another treatment modality in cases of your unresectable or your metastatic insulinoma. Now the last topic for your pancreatic neuroendocrine tumors, which is important, is your non-functioning pancreatic neuroendocrine tumor. It is seen in approximately 60 to 90%, and a head is to body is to tail ratio is your 7:1:1.5. So I have included this table from your Bailey and Love, which has been recently added. So how do you evaluate your non-functioning pancreatic neuroendocrine tumors? We check for the clinical presentation. In biology we have your chromogranin A and the PP, which is elevated. Then the imaging modalities include your CT MRI, endoscopic ultrasound, right. Then you have your octoscan and gallium PET CT scan. Now we check for whether it is resectable or no distant disease. Now if it is resectable and no distant disease is present, then we check for the tumor size. If the tumor is less than 2 cm, we can do a surveillance for grade 1 and grade 2, whereas surgery can be done for grade 2 if the patient has symptoms and if the patient wishes for surgery. Whereas if the tumor is more than 2 cm, then the surgery should be done with limited resection only if the conditions are favorable to preserve the organ function. And in case of grade 2 progressive disease symptom or high tumor burden, we need to go for a SSA therapy or a SSTR negative, then we need to give your chemotherapy. So what is your SSA therapy? SSA therapy is your somatostatin analog therapy, whereas your SSTR is your somatostatin receptor negative. We need to give your chemotherapy. Now in case of grade 3, we give your systemic platinum based therapy. And regarding the follow up of the patient, right, so in case of tumor less than 2 centimeter, we do a EUS and MRI every 6 to 12 months, and if there is no change, surveillance and increase in size or more than 2 centimeter, then we go for surgery, right. When the tumors are more than 2 centimeter, the surveillance is depending on your final pathology. So this is regarding your management of your non-functioning pancreatic neuroendocrine tumor. So just remember that CGA and PP are raised, then tumor less than 2 centimeter, we need to follow up. If no change, surveillance, more than increase in size or more than 2 centimeter, we go for surgery. Now if the patient has symptoms and wishes, then can go for surgery. In cases of tumor more than 2 centimeter, limited resection. Now if it is a progressive disease, then we go for somatostatin analog therapy, and if it is a somatostatin receptor negative, then we can go for a chemotherapy. Now for grade 3, we go for a systemic based platinum therapy. So this ends the discussion of our pancreatic neuroendocrine tumors, where we have discussed all the important points. So please do remember in detail regarding your insulinoma and gastrinoma, and most importantly this table over here, which is going to solve your maximum questions of your pancreatic neuroendocrine tumor with the classical features as presentation over here, right. Thank you.